Well, good. I'm going to ask you. I'm going to ask you to do the prayer. What's your number?
23.
Okay, folks. It's 8 o'clock, and we've got a couple of bills to present, and we have to be at. Some of us have to be at rules at 9. I'm going to ask Representative Williamson if he'll do the opening prayer.
Let's pray. Gracious Father, thank you for the gift of this day, Father, the gift of the opportunity to serve you. We pray you bless all of our families, bless the work we're trying to do, that be pleasing in your sight. In Christ's name I pray. Amen.
Thank you, sir. We've got a couple of bills. I'll ask Representative Lumsden if he'll do House Bill 262. What's your number? 20. Okay.
Good morning, Mr. Chairman, members of the committee. I bring to you House Bill 262. It's a bill that corrects an omission in Georgia Code 33-20C concerning medical provider directories and standalone dental clinics. The code section references online directories and printed directories. Language present in the online directory exempting the dental clinics is not present in the printed directory, and this bill simply inserts the language to provide consistency between the two.
So basically, it's just a cleanup.
It's cleaning up the language, yes.
Okay.
It's like a Provi, teeth clean.
Any questions for the Mr. Representative Lumsden? Okay, ready for a motion on this then? Do pass? Okay. All in favor say aye. Aye. All opposed, like sign. I'm going to ask Representative Lumsden to take over so I can go down there and type.
Good morning. We have another bill to present, and Chairman Smith will present that, House Bill 71. Mr. Chairman, you have the floor.
Thank you, sir. I want to apologize up front for all y'all's emails systems getting wore out last night. Well, that's what happens sometimes. I've got a little thing here I want to talk to you about prior to the actual bill. This surprise bill was sent to this gentleman from Rome. He had a procedure done on January the 10th. Part of his procedure, the cost was $2,520. Insurance paid $306. The last line of this thing says, you are responsible for this amount, $2,214. That was the anesthesiology bill for a colonoscopy. Okay. Balanced billing, surprise bills. You know, these bills are the ones that people get after they've done everything right. They have insurance, they go to a health care facility that's in their insurance network, various hospitals and all. They have their procedure done, and then 3 or 4 weeks later when they get home, after they get home, they get this bill. Sometimes it's for a few $100s, sometimes it's for a few $1,000s, and then sometimes it's for several $1,000s. If you ever get to have the opportunity to ride in an air ambulance, it could be $100,000. And we have no control over them. They are regulated as an airline. And what makes this even worse, it's normally from a provider that we don't know, we don't ever see sometimes, and they're the ones who send us these balance bills. And I'm sure most of you know this, but the number one reason people declare bankruptcy now in the United States is because of health care. let's look at the economics of this, and I apologize to those of you who were on the subcommittee yesterday, because you're gonna hear a lot of the same stuff I talked about yesterday, because it's all important. But let's look a little at the economics of this, and I'll use Columbus as an example. The median household income in Columbus is $48,000. Let's see what a couple, or at least one example would do to that $48,000. This past December, I was talking to a guy in Columbus. His wife has Hodgkin's disease. She was in the hospital, dismissed. 3 or 4 weeks later, they received a $15,000 bill. That, you know, like I mentioned yesterday, if you'd have received that bill on Valentine's, it probably would have taken the steam out of Valentine's. I also talked with a pastor friend of mine, and he says that he's glad that we're addressing this issue, because some of his members, they get these bills, but sometimes they don't get the surprise bill until 12 to 14 months after the procedure. Now, these surprise bills usually result from emergency situations or when your doctor uses out-of-network specialists. There was a study done by Johns Hopkins University where they surveyed 400,000 doctors across the country. That's a pretty good pool. And they provided a list, and this article was printed in the Journal of the American Medical Association. This is the journal for the doctors. And it talks about 5 doctors most likely to stick you with surprise medical bills. We'll get into those in a minute. Now, this article was done in the Journal of American Medical Association on January the 17th of this year. So it's current information. The senior author of this bill, Mr. Gerard Anderson, says that these bills normally come from providers that you don't normally see or choose. As a result, you usually don't know beforehand whether they take your insurance or not. People are shocked when they get a bill for many hundreds or thousands and sometimes months after they're being treated. And he says this happens all the time. And if you want to get a larger perspective of this, you need to go to an NCOIL meeting, which is the National Conference of Insurance Legislators, and this is always a topic of what's going on around this country. And Mr. Anderson said this also is happening all the time. Now, the average out-of-network physician normally charges 2.5 times what Medicare, and Medicare is normally the benchmark for where they start, and then it's always above that. But usually the highest markups were from doctors who usually you don't select yourself because of an emergency or because a specialist is brought in with your procedure. Could be a radiologist, pathologist, any of these groups that you don't normally see. So now what does House Bill 71, or the substitute for House Bill 71, do? First, this legislation eliminates surprise billing. And it does so without increasing insurance premiums. Now, we had a lot of conversation yesterday during the subcommittee, but at no point in time did anybody ever say, this is another way to stop the problem. It was always about compensation, you know, or credentialing or something. But it never said, okay, if we do this, it will stop surprise billing. The only thing I know of that can stop surprise billing is if the providers are in network. Because when they're in network, they agree to the compensation that they've agreed to with the doctor or with the insurance company, and they agree also not to send out a balance bill. Simple as that. You know, if you can tell me another way to stop surprise billing, I am ready to listen, because we've been talking about this thing for a couple of years. We've had study committees this past year So, I'm ready to listen, but thus far, the only thing I know that can stop a surprise bill is if the provider is in network. If you'll look at your bill on 33-20E-1, it's pretty much like any other piece of legislation. It's definitions. Health plan is broadly defined, and it also includes the state health benefit plan. Similarly, if you look at healthcare provider or healthcare services, these are broad meanings to encompass a wide array of situations. Then if you get down to 33-20E-2, disclosures by providers. This section provides that hospitals and other providers must do to disclose information to patients. First off, they must provide the names of the healthcare plans of which they are participating in, both on the internet and also verbally when the patient comes in. Also, the physicians must disclose additional information regarding any other providers that are brought in for a particular procedure. Now remember, under current practices, you have no say-so who will be the anesthesiologist, radiologist, pathologist, and in a lot of cases, when you go to the emergency room. Now, if you go to the emergency room with a broken arm, that's one thing. If you've been in a severe car wreck, you could go in a whole lot different situation, but you have no say-so, no control. Hospitals must also make disclosures regarding providers at the hospital so that prospective patients can find out what health care plan the providers are in. When you go in and have a procedure now, and I had a little procedure this past fall, first person you see is a person who asks for your insurance card and your ID. Well, I asked that individual, and she said this is the first time anybody's ever asked her, but I asked her, I said, how difficult would it be for you to show the individuals or groups who are participating in my procedure and tell me whether they are in network or they're not? She said, probably wouldn't be a big deal. If you go in for whatever kind of procedure, you got to have an anesthesiologist or whatever. If you're going to be put to sleep, they can list those and tell you if they're in network or not. Shouldn't be that much of a problem. So a big part of this bill is transparency so that you as a patient know who's participating in your procedure. Now, also, providers must negotiate all the terms and conditions. There's a lot of false information running around out there that said, the hospitals will do the negotiating. That could not be further from the truth. If you're negotiating, or if you're a provider and you want to be in United's network or any of the other network, well, it's your responsibility to negotiate that contract. It's not the hospital's responsibility. You may negotiate a better contract than what the hospital would. But if the hospital's got United and you got United, they can credential you. There's no problem. You don't have to accept what the hospital does. You're your own negotiator. And the hospital is the same way. They are their own negotiator. But the only way you're going to stop these surprise bills is if the provider is in network. That's the only way it's going to stop him. And there's a couple of procedures we put in this bill to ensure that. Those of you who are in the insurance business, you know what kind of power the insurance commissioner's got. Pretty much with a stroke of a pen, he could expel any insurance company out of the state of Georgia. He's got the power to do that, and he's the one that would enforce the good faith negotiation with the provider. Okay, the provider also wants to be in network so that they can have credentials at the hospital, because that's one of the requirements of having credentials at the hospital. Both of you are in the same network. You're in United Hospitals, and you can participate. So the hospital would be encouraging you because they want you as a physician there. But also, good faith with the providers, you got DCH involved in this now too. One of the common complaints I hear is that, well, the insurance companies don't come talk to us, and then you talk to the insurance companies, then they say, well, the providers don't want to talk to us. So this is going to force them to talk and have good faith negotiation. But, and two, I think this was some of the emails that y'all may have received last night. It says, well, you're taking away the power of negotiation for the provider. Well, we are requiring them, both parties, to negotiate in good faith. And I've told both parties in one form, fashion, or another, if you don't negotiate in good faith, I will be sitting back here again next year with a bill that you really won't like. But this allows you to negotiate and forces you to negotiate. That's the crust, the main thrust of this piece of legislation. But I can tell you now, like I said, we heard a lot of discussion yesterday about compensation and fair health and all this. The only way you're going to stop these balance billing, providers have to be in network. And like I say, if you can find a simple answer, I'm ready to listen. And once you're in network, the provider has agreed to the compensation rate, and they've also agreed not to send out a balance bill. And I don't know if too many of us want to receive a $2,200 surprise bill in the mail, or the person who had the $15,000 surprise bill after they got out of the hospital. And you hear these kind of horror stories all the time. So our responsibility is to help the patient get out of this mix, and that's what this bill does. It takes the patient out of the mix that they no longer receive a balanced bill. I'll be glad to answer any question, but that's pretty much the thrust of this. I know there's a lot of discussion outside on the internet and emails and this kind of thing, but that's okay. But nobody, we've been having this discussion for a long time, and nobody's told me another answer yet. So I'm ready for a question.
Members of the committee, you've heard the testimony. Do we have any questions? Number 22, Representative Carson.
Thank you, Mr. Chairman. And Mr. Chairman, I really appreciate your work on this. I know this is a major issue. I've not heard from a lot of constituents in regard to this, but I'm sure it's something on their radar. I just had several questions. One, can you share with me what other states are doing in regard to surprise billing? What have their efforts been recently, maybe within the parameter of NQUIL or possibly not? Particularly our border states and other states in the Southeast, how are they addressing the issue of surprise billing?
To be honest with you, I can't tell you. I know a lot of them are discussing such things as fair health, being the compensation being paid based on a percent of fair health. I know yesterday in the Senate version, when they were having their hearing, the sponsor of the bill was proposing a compensation of 60% of fair health. Another senator amended it to raise it to 80% of fair health. And see, fair health compensation is based on bill charged retail costs, not negotiated costs. Mm-hmm. And to give you an example of what that may mean, if I can find one of these things, there's those CPT codes where you get charged X number of dollars. Sure. For a particular procedure. Just as an example, first one on the list, excuse me, injection in the spine or cervical or thoracic area, the average Medicare fee was $113. That's what Medicare says they'll pay a doctor. Mm-hmm. And doctors who accept Medicare have to accept that, and they cannot send a balance bill. You cannot send a balance bill to Medicare. or to a Medicare patient. Then, the average out-of-network, I remember $113 for Medicare. The average out-of-network charge, and this was submitted in 2013 through 14, this latest data I've got, their out-of-network charge was $1,152.
The Medicaid was what in
The Medicare, not Medicaid.
I'm sorry, Medicare,
Was 113.
the retail?
The retail was 1,152 for the exact same procedure.
10 to 1.
That's over 1,000% increase. And you can go down this chart and see all kind of examples where you have the same situation occurring. But that's where they're, some of your, I know Texas has a situation. I haven't read Texas's bill, but they have a part of their bill where, if the provider and the insurer can't come together and negotiate a price, then they can have some governmental agency go through a administrative law judge or somebody go through some negotiation process. Currently, they have over 500 of those in process.
Could I ask more questions?
Sure.
I have one more comment and then another question. As legislators, we all get a lot of emails that are automated emails, and you just fill in your name and your address, and we get something, right? We get all those form emails. What I would like to say to the chairman of the committee is I'm very, I don't know if the word overwhelmed is correct. It probably is on this computer, but in regard to the number of specific emails, these are not form emails. These are people saying these bullets or so forth, or they're making their own points and they're coherent sentences and so forth that are very well crafted.
Yeah.
My point is just as a comment, these are not form letters.
Right.
These are people with specific, thought out objections, serious concerns about the bill. And to me, I'm up to 84 in the past 20 hours. That it speaks a lot. Can you talk about the process that's been going on with regard to the doctors and the hospitals in regard to get them on board with trying to come up with some sort of solution the past few months? I know maybe you already covered that a little bit, but
Well, we've had open dialogue with any group who wants to come in and talk with us. We've met a couple of times. Senator Unterman had some hearings this past fall. We participated in those. We've had, I had someone in my office. I got there at about 6:45. They walked in about 7. So we've had dialogue with practically every organization group that is impacted by this. What you're getting on your emails are probably 99% from or plus is from providers.
providers meaning specialists, radiologists, anesthesiologists, things like
Correct.
that. Okay.
Mhm. But I'm open. If somebody can tell me how you can stop a surprise bill from coming, if they're not in network, tell me how.
And I guess the crux of the matter is if maybe the hospital accepts, I'm just going to pick on Aetna, because that's what I have. So if my hospital accepts Aetna and the main surgeon accepts Aetna for a non-emergency service, that doesn't necessarily mean the anesthesiologist or
That's true.
others. So if we require, this bill requires disclosure of those non-emergency?
Yes.
Okay. It does not require those providers on a non-emergency basis. It does not require those providers affiliated with that hospital.
If they are hospitalists, doctors who work for the hospital, they're already in network because
Right.
they're in network for the hospital.
Right.
But if they're an outside group, like normally your radiologists, your anesthesiologists, your pathologists, emergency room doctors, because sometimes emergency room doctors are contracted. I was talking to somebody the other day, they went to an emergency room, and the emergency room doctors was a group out of South Carolina. But if they're going to be credentialed at that hospital, they need to be a network, or otherwise you're going to receive a surprise bill. Because those doctors, you don't ever see. I don't know a pathologist.
But isn't that almost a two-edged sword? Whereas if you require them to be a network, that gives the upper hand to the insurance companies to mandate rates.
Not when we have specific language in there that says that it will be good faith negotiations. The other question you have to ask on this is, why is it most other doctors are already in network? The doctor you see every day or every time you go in for your general practitioner, all of those doctors are in network. You've only got a small group that's not.
Well, and to your point, though, I would think that it would be incumbent upon providers to negotiate, as opposed to for what you mentioned. The bill you said was, what, 12, 18 months old, or 12 to 18 months from the date of the procedure? Is that correct?
Well, on this procedure, it was done on January the 10th this year.
But there could, on
There
the
have
balance many times, there is a
Yeah, they
pretty
could be a 12
significant
to,
lag, is there
they're
not?
12 to 14 months based on that pastor I was talking to.
Okay.
We have some other questions. Representative Blackman, 15.
Thank you, Mr. Chairman. Appreciate what we're trying to do here, Chairman Smith. I just real quick wanted to ask, do we feel like access might be an issue, potentially enacting legislation like this with respect to doctors and so forth?
Well, I would think that, in order for example, like on this particular case, about the only place an anesthesiologist can work is in a hospital or a hospital type setting, and that's where they make their money. They keep talking about doctors pulling out and this kind of stuff. Well, this is where the doctors make their money. A lot of them make money on office visits and this kind of stuff, but most of the doctors I go see also have hospital privileges.
I ask one further question, Mr. Chairman.
Yes.
I think we probably all gotten a surprise bill there. At some point or another, and obviously this would greatly benefit that. I just, with respect to cost, do you think this would raise the cost in any way on anyone?
I can't see where this would raise the cost on anyone, because your premiums shouldn't go up. And when you have good faith negotiations, and and I know that your insurers and your providers, there's more trust between them than there are pharmacists and PBMs, but sometimes they don't feel like there's good communications with them, and one group said, well, the insurers don't even contact me. Well, they will now. So why would it? You'll have negotiations between the two.
Thank you, Mr. Chairman. Thank you.
Representative Williamson, I believe.
Thank you, Mr. Chairman. Are you aware of any other service offered in the world for anything that we don't know the price up front, like is the case in medicine?
This, I think, is about the only one that you have this kind of scenario. Even when you go buy a car, you see the list price and then you negotiate. Or in this case, you go in and it's a hope and a promise when you get out.
And so, because nobody's going to build a home without knowing how much it's going to cost or anything.
That's true.
And it's sort of an intractable situation. But from my perspective, I trust you and your leadership is trying to find a compromise. Isn't it true that you worked very, very hard on our firefighters bill? It was a very, very difficult situation and pulled together. I feel like you pulled a rabbit out of the hat. Isn't that true?
Well, I appreciate that. Thank you.
So-
there was a lot of people that worked a lot of hours on that.
Well, and I know that I personally feel like we have a lot of more work to do on this particular issue, and I've received emails last night from personal friends of mine that are physicians that are hardworking and great members of our community, and I trust their opinion eminently. So I've got enormous amount of sympathy for what they're saying, but I've got an enormous amount of trust in you as our chairman of insurance to help us find I don't believe this is exactly where we're going to end up being, but I trust your leadership to get us there. So for that reason, this representative is going to be voting yes on the measure because I trust you. So
Thank you,
is
sir.
that not true?
I hope so. Thank you, sir.
All right. Representative Shaw, number 17.
Well, Bruce, you stole the words right out of my mouth, so thank you. But I feel the same way that everybody else's comments have been. I'm getting these emails, and they're not form emails. And the ones prior to that were on the other side. But I know you and I have discussed this in detail for a while, and you've worked real hard on it. But my biggest concern is that that we get something done, number one, because it is such a major issue for all Georgians. But we have major issues in rural Georgia recruiting doctors. And I just want to make sure that whatever we do, we don't tilt that leverage pendulum, so to speak, to make that even harder. And just as Bruce said, I will, or Representative Williamson, I trust you because I know you well enough, and one of the most respected members of this body. And but it is a major issue, and I know that you're going to keep that open door, and we're going to keep working on this thing and hopefully move it towards that type of negotiation that needs to happen.
Well, thank you, sir. I sympathize with rural Georgia. There's several counties that don't have doctors. There's several counties that, let alone a hospital. There's several counties that don't have dentists or anything else. So I'd do anything in the world to help rural Georgia because we have some real health issues when you get to the fall line and go south. Trauma care, all of these issues that, and you go in southwest Georgia, you got some real service industries down there that need some help as far as in the healthcare industry. There's just not much there as far as doctors, hospitals, anything.
And one follow-up question, if I may. And we really all know part of the root of this problem is the fact that, I'm going to go back to rural Georgia. I mean, you've got limited access as far as providers, but you've got limited access to insurance carriers. And if you've only got 2 carriers and you can't negotiate with them, then you're not going to be able to practice in that
Yeah.
community. So,
Well, I think you're exactly right as far as, because I think with the Affordable Care Act, there's only one insurance provider that's covering the whole state, something like this. So that presents some problems. So we've got to, they've had numerous studies in the legislature about hospitals and, what the role of a rural hospital is and what we can do to provide services for these hospitals. And you've got several of your hospitals around the state that are not operating in the black; they're operating in the red. So it's healthcare in rural Georgia is a big issue.
well, and like Bruce said, though, this really hit home, I'm sure, with all the committee when you start hearing from those people that are your friends and the people you respect back home, the care providers that do such a good job. And it really didn't start until after 4 or 5 o'clock yesterday, so it's a little hard to communicate with them, with everybody and call them back that quick. But I'm just telling folks that I know you, and I know that this process ain't over, and we're going to try to keep listening to ideas and try to solve this issue. So thank you for your work.
Well, thank you, sir. If somebody can come up any time after this meeting and give me a better solution to stop balance billing, I'll throw this out and we'll go that route. But we've got to pull the patient out of the mix. Thank you.
Number 4, Representative Hughley.
Thank you, Mr. Chairman. To the chairman, Have you thought about, I know you said that if this doesn't work next year, we'll be back, but have you thought about having something in the legislation that would require us to come back and take a look at this to see how it's working? Because it is a new adventure for us. And, you know, not everybody's going to be in these same seats the next term. And we want to make sure that we don't have any adverse impacts on the marketplace.
There's nothing in the legislation itself to have another hearing on it in 1 year, 2 years, 3 years. But I can assure you that when, if it passes this committee and it passes the House and the final version that comes out of whatever the House and Senate does, there will be language added to make that happen.
Thank you.
Representative Maxwell.
Thank you, Mr. Chairman. Mr. Chairman, I appreciate what you're doing on this bill. It is a problem, and tie on to what Chairman Shaw said. We left the meeting a little after 4 o'clock yesterday, and by 10 o'clock last night, I got in. I probably had 25 or 30 emails addressing this, and it just befuddles me with all the folks who were in the meeting yesterday. I don't know how many we had. I was in and out different meetings. Probably 25 people testify, I guess. There's some network out here somewhere that people are communicating. I swear to goodness, by the time they left at 4 o'clock and we started getting emails shortly after that, it just befuddles me in my simple little brain that with all the network going on with that and people communicating to doctors, and I'm sitting here and I got a call from my cardiologist, and I know he's probably not happy, and that bothers me a little bit because I got to go see him next week.
Maybe one of those things are not coming back.
Yeah.
Just hope it's not your anesthesiologist.
Yeah.
You might sleep a long time.
I sent him the voicemail. I didn't get up and answer the phone, but there's a network out here somewhere. People are able to talk to each other pretty quickly. I mean, from 4 o'clock till 10 o'clock last night and getting 30 or 40 emails, it looks to me like there's be some way that, you know, with all the other communication going on, that these folks could talk to one another and get this worked out. Like I said, I'm not that smart. I can't figure it out, but I appreciate the work you put on it. And I think we got a good starting point here. And like you said, I heard everybody had their problems, their complaints, but dadgum, nobody brought up a solution. If you don't like this, tell me what else you think is going to work. You know, like you've asked for. If this is not what you like, show us your opinion, show us what you think is going to be better, but let's get it solved so these people won't get a bill. I got a lady in my office, went to her regular doctor last year, had blood work, and they sent it to an out-of-network, and she got a $450 bill because they processed the blood work out-of-network. Called them, said, well, I'm sorry, yeah, we had to send it over there, and nothing we can do about it. It just doesn't make sense with the way we're able to communicate and get things quickly moved around here. There should be some way that these people could talk to one another. But I appreciate your efforts, sir, and I'll pray for me when I go see my cardiologist, I guess.
Representative Hawkins.
To my friend, I'm going to say a few things before I ask a question. I've been practicing 40 years. I've had students come through my office. I'm an adjunct professor, who my fees are 80% of theirs. In 40 years, I've never had an insurance company pay my fee. And I often wonder, would they keep me on their insurance rolls if I decided to pay them 80% of what they charge me? And I know the answer to that. And I'm not real sure who decides Medicare and Medicaid fees. Yesterday I went to the banking lunch and sat next to Infinity Bank and asked him, I said, how many students, dental students, do you loan to in rural areas that have high Medicaid patients, numbers? And he said none. He said, we can't loan to them because they can't make a living. They can't pay their loans, much less pay us. So this is my question. Should we establish a good faith legislation first before we move on this? Because I have all the confidence in the world in you. I really do. And my vote's going to be no, and I know you know that. But should we not consider that first? To make this mechanism really work well? Because I'm really afraid that we're losing docs my age, and that's fact. And I'm concerned that some of my colleagues are gonna feel like this is the last rock on their wagon, and they're gonna go into retirement because they can't operate in the hospital where they have to. You know, and they're shutting their office down. I shut my office down when I was on hospital, and I did hospital dentistry for about 10, 15 years, and I had to shut the office down and go do it, then come back and open the office up. So it wasn't just a 30, 40-minute procedure in the hospital. It really turned out to be close to 2 hours. So I know the fees look sort of high, but if you saw what I was paying, you know, to be able to keep that office open. But anyway, I'll get off that. The question again is, should we establish good faith legislation first?
We've got some language in this bill that requires good faith legislation. It requires the insurers to negotiate in good faith with the providers. It's like I mentioned earlier, the department that has control over the insurers is the insurance department. They have the stick that can force them to negotiate in good faith. The providers should be negotiating in good faith because they want to go to a hospital and work and this kind of stuff. Plus DCH is involved in this. But it's like I told the insurers and the providers, if this doesn't work out as far as the good faith negotiation, like I said, next year I'll be sitting right here, but it'll be the first day of session, and it will be a bill that they really won't like. Because there will be good faith negotiation, or like I said, I will be back.
Representative Raffensperger.
Good morning. Thank you, Mr. Chairman, for bringing your bill. And thank you for your focus when you talked about the taxpayer making $48,000. And I think at the end of the day, I think that we really have to always look for the person that's paying the freight, which is the taxpayer or the person paying those bills that come in. So thank you so much. And as I was thinking about this, as an engineer, we are, I guess, the lower rung of the professional, and the medical community, our doctors, are esteemed for what they do, because I think after 4 years of college, then they go another probably 8 to 12 years as they get their degrees. So I highly respect our medical profession. And so I hear what they're saying also, and what I hear, I think, from them is their concern that they feel that the hospital may be the 800-pound gorilla, and they'll be in the same boat with the taxpayer, the little guy, and that they really won't have a voice on what really happens. So I was thinking about this, and I know in the contracting business, we actually end up with disputes from time to time. We prefer not to have them, but many times we have mediation clauses. And I didn't know if there was some type of a dispute resolution in there when people say they have good faith, but there isn't. And so that we somehow have the sword of Damocles, you know, over their heads saying, well, if you can't agree, let's have a mediation so that we can move that forward. And is that in there, and is that, you know, taking that practice from the contracting industry, is that something that we can incorporate here so that everyone feels that they have a fair voice? Because I believe that what you're trying to do here is tremendously worthy and noble, because you're looking out for the person that gets that surprise billing, and $15,000 for a person making $48,000 will put them into bankruptcy, or they're in a major hurt for a major period of time. So
Right.
thank you, sir.
There is no mediation clause in this. Texas, in their version of this bill, has a mediation clause, and currently they have over 500 lined up to go through the mediation process. And this, you know, if you're going to start doing a mediation, and I know this, the Senate version has a mediation clause in it, but then if you're going to go through a mediation procedure, then we will have to have a physical note, because you will have to hire staff in order to do these mediations. No, but there is no mediation clause. But like I said, when, you know, it's kind of bogged Texas down.
Thank you.
Representative Williamson? Representative Williamson, do you have another question?
I'm sorry,
You're on.
Thank you, Mr. Chairman. And Chairman Smith, you know, it just strikes me that we were blessed to have Dr. Mark Newton join us as a representative in this body, and I was wondering whether or not you could have had an opportunity to talk to him as a trusted healthcare professional, and would you commit to sitting down with that member of our body to as you've already pledged, to continue working towards a final solution to this very real problem we're facing?
Oh, yeah, I'll be glad to, he and I have talked on 2 or 3 occasions, but I'd be glad to sit down, and I'll sit down and talk with anybody. You know, we got a couple of doctors in the Senate, and, you know.
We like ours better.
Yeah, we like ours better, I understand. Yeah, I'd be glad to send it, but, you know, what the goal of this piece of legislation is to get the patient out of the mix, and until somebody shows me a better way to do that in network, as far as I'm concerned, is what we've got to go with. Now, like I said, if somebody shows me a better way, we'll go. I'll throw this in the trash and we'll go with another route. But you know, this is the beginning of the process. Not only does it have to get cleared through the House, and if it goes to the Senate, you know, then the Senate has their version. So there'll be a conference committee, and you know, there'll be a lot of discussion on this bill before March 30.
Again, that's why I trust you on your leadership for this,
Thanks,
on this
sir.
matter.
All right, I don't see any other questions. Do I hear a motion? To pass and second. All in favor, say aye. All opposed, no. I believe the ayes have it. I believe that concludes our business this morning. Thank you for being here.
Thank you, sir.